I'm Okike. I'm a pediatrician, and I'm a part of the BPSU Scientific Committee. And it's my pleasure now to kick off this meeting as the president-elect of the Royal College of Pediatrics and Child Health. Dr. Camilla Kingdon will be introducing today's event.
Thank you very much indeed. So welcome everybody to this event. It's a huge honour to be invited to make some introductory comments at this, which is the second day of the British Paediatric Surveillance Unit and Public Health England Symposium. Now, I should say that as a British paediatrician, I come from a generation that thinks of the BPSU and orange cards in the same instant. And I know that sounds a bit odd to those of you that don't come from British paediatric circles, but essentially, traditionally, the BPSU would send us an orange card in the post every single month with a list of the conditions that they were interested in and surveying. And it would be our responsibility to tick any relevant boxes and return it. And I can clearly remember my orange cards kind of burning a hole in my in tray until I'd completed for the month and posted it back. Of course, now it's all done online, and it's much more a much simpler process for online for monthly reporting. But I think it's fair to say that the BPSU is hardwired into the working lives of paediatricians across this country, and remains a very treasured and important arm of the Royal College of Paediatrics and Child Health. So this evening's symposium is a collaboration between the BPSU and Public Health England, and we're focusing on COVID-19 from the paediatric perspective. The BPSU's got a very long and illustrious career, which now stretches almost 37 years of surveying for rare diseases. And it's worth remembering that of about 34 of those 37 years has been spent, for instance, surveying the incidence of HIV infection and monitoring pregnant women, and then keeping an eye on their children, in order to give us detailed and comprehensive data, so that we have a clearer understanding of the disease epidemiology and so on. And examples like that are why the BPSU is such an incredibly important part of our working lives in this country and how we care for children and young people. Now, in the last year, the BPSU has shown its agility and its resilience in how it's been able to respond and collaborate with partners like Public Health England in responding to what has really been the biggest challenge that's faced the world since the Second World War. So in a very short space of time, the BPSU and Public Health England were able to respond to the developing pandemic and embarked on several studies that we're going to hear some of which we're going to hear about this evening. But all studies relate to children, and they were able to do this at speed in response to the crisis. And the studies, all of the studies, rely on clinicians and non-clinicians up and down the country sharing real life data with the single aim of improving the health and well-being of children and young people. And we've seen some fabulous examples of that. We've looked at vertical transmission of COVID-19 to the neonate. We have sought to understand the multi-system inflammatory condition that in the UK we call PIMS-TS, and we're going to hear more about that this evening. But the key message for me was that these studies weren't just to inform diagnosis and management and all the kind of medical ramifications of this. What was equally important was about keeping the public informed and to allay the fears of parents and children and young people up and down the country by giving accurate information. And I think this pandemic has taught us that clear and accurate information for our patients and for their parents is absolutely vital to help people make sensible decisions about the spread of infection, for instance, about when it was safe to go back to school, and so on. And the BPSU and Public Health England has played an absolutely crucial role in all of this. It's about establishing confidence and clarity of guidance, And I think, this is going to continue to be really important as, for instance, the vaccination program is rolled out globally. Never has it been more important that the public are confident about the information they're receiving. And I'm pleased to say we're going to have 2 talks on vaccination this evening as well. Now, the issue of providing accurate and reliable information to children and to young people and to their families is something that we actually take very seriously at the Royal College, and therefore also at the BPSU. And to do this meaningfully, we work with a huge number of children and young people, and the voice of children enters into and threads through all our work and all our projects. And so I'm especially delighted this evening that we're actually going to hear from a young person, Oliver Lawton, who actually studied how information is accessed during the pandemic. And he's going to be telling us some really illuminating information that he discovered and help us to understand it from a young person's perspective. So that's going to be a really fantastic talk shortly. Now, we know that children have not been the face of the pandemic, but we do know that they risk being the biggest victims. And I think children of all ages and in all countries have felt the impact of the pandemic. And sometimes the mitigation measures which have been taken by governments have inadvertently done more harm than good. And the distribution of the impact has not been felt evenly. Has not been spread evenly, and a disproportionate burden has been felt by some of our poorest and most socially disadvantaged families. And so we're going to hear about that this evening as well, and that's another really, really crucial topic. Now, I know time's of the essence, but I want to very quickly inject a note of optimism into this evening's talks. I think it's very easy and completely understandable for us to dwell on the disaster that has been this global pandemic. Every single one of us has been affected by it. I dare say every single one of us has shed tears over this pandemic, has felt anxious, has worried about the well-being of our families. Awful things have happened to people all over the world. And so it's understandable that we think about this with sadness and fear, but I think it's really important. And I think we owe it to the children of the world that we actually learn not just the lessons of the pandemic, but that we also see some good, and we think about what good can come out of it. And I was really struck recently, Michelle Obama she didn't come, she virtually met with a group of children at a North London high school that she's formed a relationship with over the years. And she really challenged them to think about the opportunities that this pandemic has brought them. And she asked them to try and think about the learning and particularly around how they were going to find the learning to help them navigate their way through life, and particularly for times that they're poorly prepared for. And I want to quote something that she said. She said, "I would view this as a great blessing to you all. Right now, you are learning how to get through something hard and uncomfortable and unpredictable. No matter how high you get, or how smart you are, or how successful you are, life will throw you things that you are not necessarily prepared for. And if you know how to get yourself through it, you'll succeed." So I think there's a message in that for all of us. So let's learn all we can from this pandemic, and let's work together to support the health and well-being of children everywhere. And I think the work of the British Paediatric Surveillance Unit this year really epitomises how important it is to turn adversity into advantage. And I think the programme of talks this evening looks to me like it's going to make that abundantly clear. So thank you for inviting me, and I'm really looking forward to the rest of the evening. Thank you.
It really was a privilege to have you opening this symposium, Camilla. So we're very grateful to you. And you're right, I think that we still have a little bit of battle left before we go back into our routine life for children. I think that the next 6 to 12 months are going to be very challenging for children and for pediatricians as we move back towards normality. And it's important that we don't get lax now in terms of schooling, in terms of education, in terms of social health and medical health. And it's really important that we drive this so that we don't get left behind in a year or two. So without further ado, I wanted to introduce you to Dr. Okike, a very close friend and colleague of mine for more than 20 years now. We trained together back at St. George's many, many years ago, and we've continued to build a partnership with research across that time. We've been involved in a lot of BPSU studies together in that period. And it's a real pleasure to have worked with him during the pandemic, where we initiated a school surveillance right back in June when schools were just about to open. And he's going to tell you about what we have learned from schools in terms of infection and transmission within educational settings, and what we need to do to make sure that schools stay open in the coming months. Okike, the floor is yours.
Thank you very much, Shamez, and I'm really glad that I've been given this opportunity to speak about COVID in schools and what we've learned. Can I just tell you that I'm only an agent because I'm representing these lovely colleagues of ours who's made all the studies I'm going to talk about possible. So I can't name them individually, but you can see their names and they know who they are. So in the next 10 minutes, I will be addressing current infection of SARS-CoV-2 in children, looking at a surveillance in school study. And I will also be looking at previous infection using two studies that Shamez alluded to. And I will try and tackle the issue of outbreak and transmission and give opportunity to two fantastic teachers from local schools here talking about real life experiences. And we'll try and address next steps. So it's quite a very long journey that we're going to take. And of course, early in the pandemic, we all knew that the rate of symptomatic infection, hospitalization, and death was low in children when compared to adults. But that rapidly changed when the increase in cases were being noticed across the globe. Of course, this led to interventions and mitigations, some of which led to lockdown and school closures. And we know in certain countries, school closures were done in different ways. In our own country, here in the UK, schools were first to close on 20th March, and then there was lockdown on the 23rd of March. And subsequent times in June, we had a partial reopening of schools, and then in September, there was full reopening of schools. And I'll come back to that when I'll talk about the data we collected from schools. In this time also, people had concerns. Of course, school is a big environment that has a large number of children gathering, albeit in small numbers, but we had a total of 9 million children going to school in the UK. Of course, these young children, social distancing will be alien to them. It's something new. People didn't know what the infectivity in children was. And in fact, there's all the ongoing debate about the transmission and the role of children. And also these vibes about asymptomatic infection in children and how you measure infection, including finding active cases and not just relying on symptomatic infections. So I'm going to share, first of all, what we learned from schools using current infection study. And this study is really important because it was conducted by a collaboration of the Public Health England, ONS, which is the Office for National Statistics in the UK, and the London School of Tropical Medicine. So it's called School Infection Study, and this included 150 primary and secondary schools. And most of the secondary schools were weighted towards schools that are of high prevalence during that time. So this study took nasal swabs and antibody using oral fluids from children during the school academic year, the 2021 academic year, and that academic year started in September. There were 105 schools. I won't bore you with the numbers, really, but this is a big study. And of the schools who were involved, just under half of them had no current infection, and 29, this is about 28%, had one current infection. But what is really striking here, so if you're looking for current infection, there is only 1.2% in pupils compared to 1.29% in adults. Now, if you looked at high prevalence areas, so areas where there was high prevalence of cases during that time, it was slightly higher, 1.47% compared to schools where there's low prevalence. And this really shows us that it correlates with what we knew already from the National Public Health England, that when there's low community transmission in adults. There was also low transmission or rate infection in children. And likewise, when you had a higher community transmission in the community, that's also reflected in children. So it therefore tells us that the rate of infection we're seeing in the school was also a reflection of what was happening in the community, and it was not higher in schools. The other way of looking at infection from schools, I mentioned earlier about asymptomatic infection. So we had to think about ways, and one of the ways of looking for that is antibody testing. So antibodies would tell you a current infection, but then tell you about infection that has happened in the past as well. So, and it will be able to give us information on asymptomatic infection or mild, or what we call transient infection in children. And we were able to see if we can tell who are the drivers of infection in schools. And this is where my colleagues and I came together, and the study was quite a big study. As you can see, we have a study set up SCIDS for surveillance in primary schools, and in the UK, primary school age is between 4 years and 11, and secondary school is 11 to 18. So there were 132 primary schools across 6 regions in the UK that took part in the study, and 18 secondary schools in the same regions that took part in the study. And I would just focus on the antibody results. The first thing you will see here is that I have just grouped the primary schools and the secondary schools within their regions. What we found was that antibody seropositivity measured by antibody to the nucleoprotein was similar across staff and students. And this is really important because obviously there was the fear that where the infection was coming from within schools, whether it was students or whether it was from staff, but actually everybody had the same rate of infection. And when we looked at the beginning of term, and also when we looked at the end of term, so what happened at the beginning of term kind of simulates what happened in the community before the kids came to school, and what happened at the end of term should reflect the interaction that's happened within schools. And I'm going to just bring you to even more exciting part of the results. So when you look at seroconversion, and so seroconversion tells us about how many, the proportion of students or staff who then became positive within the time interval. So round 1, like I mentioned earlier, was at the beginning of the partial relaxation of reopening of schools. And during that time, certain years were allowed to go back to school in primary school. And in that time, this was the baseline results. And then round 2 were antibodies taken or blood tests taken at the end of that particular summer term in July. And then round 3 was the end of autumn term, when there was already full reopening of school in September. So what you can see clearly here, just for primary school, the seropositivity for students was 11.2%, and that for staff was 15%. And now when you look at seroconversion, very little, 1.2% for students and 0.2% for staff. And then we went back on the round 3, which is when there's already full reopening of schools in November, December. Again, the seropositivity rate hadn't increased by much, and very similar across the staff and the students. So there is that theory that students or children were passing this virus between themselves and to the teachers was not actually held based on this study. Similarly, when you looked at seroconversion in secondary schools, of course, secondary school is slightly different because their full reopening was in September. So we went in within the first few weeks of school going in, and that's round 1. And the second round, again, was around November, December. And we were able to, again, show that the seropositivity rate for students and staff, very similar, 12.8% for students and 9.2% for staff. Again, when you look at seroconversion rate, similar, although a bit higher for staff, but not significantly higher, 6.5% and 8.3%. Again, shows that there's a higher seropositivity rate in secondary school, but the seroconversion rate were similar. And again, tells us that we do not see this asymptomatic infection and infection transmission between students and staff as initially taught. Now, these are some of the risk factors for those who actually had the COVID-19 infection among students, among staff. So there's a bit of ethnicity and someone being unwell in terms of in their questionnaire, asking them whether they were well or unwell during a period of time before the study, and having a healthcare parent, a healthcare worker as a parent, or for the staff, a healthcare worker living in the household. Interestingly, age, sex, or being in attendance to school, or other key workers, because there are key workers that were allowed to work during the lockdown as well, but they're not healthcare staff. And frequency of school attendance, again, was not a significant risk factor in a multivariable analysis. And this is really important. If we put our study from the UK into context by looking at other studies, I just picked up one study from France, and they were looking at children of kindergarten age, so five months to about 4 years of age. Again, they looked for antibodies similar to what we have done, and they found that the rate of seropositivity was 3.7% in children opposed to 6.8% in staff. Again, very similar, and that reflects what was happening in their community at the same time. As you see, I've shared our numbers previously, and our numbers again was similar to community transmission. So really, from these studies, we know that children and young people are as likely as adults to get the infection. But the asymptomatic infection that we all talk about and hear about, it does exist, but those children are not the drivers of infection in school setting. I've shown you that seroconversion rate was not different between students and staff. So we do need to look for where this source of infection will be coming from, and it's very likely that these are actually a reflection of what's happening in the community, particularly the households. I want to touch briefly on outbreaks in educational settings, particularly when schools reopened fully in United Kingdom, particularly in England, because this data is from England. Of course, there are reports of outbreaks, and we do have a good surveillance with Public Health England. So out of all the schools that were contacted, so 3% of primary schools and 15% of secondary schools in England reported an outbreak. But what is really important is that when they went to look for further cases following that, attack rate in secondary schools was only 1.2%, and that was in primary school was 0.84%. And you can tell because secondary schools are larger, so of course they had larger outbreaks, and it was happening across more year groups. So it could be because of the size of the schools. And then in those settings, attack rates and outbreaks were higher in staff compared to students, given the percentages I've shown here. 59% in primary schools had an outbreak that was probably linked to staff, compared to 27% in secondary schools. And in those contexts, the teaching staff were more likely to be the index case in primary schools compared to secondary school, where it's about a third. In order to put this into international context, I wanted to show you what others have found, both in the USA and in some states in the United States of America. Yes, when you look for it, you will find outbreaks. But what is really striking is that when those cases are then being followed up to see if there's secondary attack rates or cases from there, in Italy, they only found that only one case, 1.8% of the schools were affected in terms of outbreaks. And then more than 90% of them had only one case in the school, and about one school had more than 10 cases. So it's really important. And of course, the measures that they took, they closed 15.8% of the schools, and I suppose that would help in reduction of the cases. Again, in Italy, in another region of Italy, secondary attack rate was deemed to be about 3.2%, and in primary schools, and then in middle high schools, they have a different setting to us. It was about double, 6.6%. Again, very low numbers. When you look at North Carolina, again, they looked at over 90,000 students, and most cases, yes, there were outbreaks, but only 32 of those 773 had an additional infection identified when they did contact tracing. Similarly, in USA, again, secondary attack rate is only about 3.7%. And in New York, again, reason similar, trying to find out what happened to cases when there's an outbreak or reported outbreak. Again, very low numbers. We're talking about 0.5% tested positive of the contacts tested. In Netherlands, This is a different age group, obviously higher high school age group. They found out that over half of the cases in secondary school clusters were acquired outside school, and this could be one of those ones that could be attributed to super spreader events, because these children probably do things that meet outside school area. So it's really important to know that the risk of acquiring and transmission within school is very low and has been demonstrated in our context and internationally. Some of these outbreaks that we're talking about are actually very individual or stochastic, in the sense that they are random. And whenever there are attacks or whenever there are outbreaks in school, they're very similar to what is happening in community. So they simulate community transmission. It's important also to for us to put into context what's happened in schools with other institutions. For example, I've shared about the seropositivity and seroconversion rate in schools, but we need to think about places like care home. In a study from England, we found out that 2/3 of staff and elderly residents were seropositive by end of the outbreaks. This is really significant and completely higher than what we've seen in schools. In a London hospital, again, 35% of staff were seropositive by antibody testing. And we know in jails and in detention centers in the US, it's about 50% and over 50% were testing positive during the outbreaks. I think based on all this and the data from the UK Office for National Statistics, they did conclude that teachers are not at increased risk of COVID, either the infection or death, compared to other professions, which is really important. And some of this data was put in, and that helped in the return of students to educational settings. I did a very quick overview looking at international comments and reviews that have been put through, particularly regarding schools. Of course, we know, as I mentioned earlier, that early on, we know the rate of infection was low in children, but we do now know that there is increasing reports that in some parts, about 20% of cases are seen in young adults. Everybody believes and think that the role of children in transmission in school is really very limited. Attack rate and positivity has been very low in schools as well. That children are generally not the transmitters to a great extent compared to adults. And many transmissions that have been seen are seen via family transmission. So it's really important for us to think about ways we can support school, and because closures alone will not prevent deaths, as shown by the review by Viner et al. In the sense that this risk and benefit has been the reason for which school remained open. And I just wanted to share this slide with you, that when the schools reopened in March, this is the only time where there's national lockdown and schools reopened. Everybody was expecting a great increase, but I put a little upsurge. There's a little increase, but actually that has come down quite nicely and remained to come down. And for that reason, schools' doors have been open for children to continue schooling. Really, in a very kind of whistle tour way, I wanted to share with you today that COVID infection in school-age children really follows what happened in the community, especially in the school-age students. Infection and seroconversion rate remains low between school students and staff, even when school fully reopened in September in the UK context. Of course, outbreaks do happen, I've said it earlier, but secondary cases from that are very few. And we need ongoing surveillance, particularly with the emergence of new variants. It will be my pleasure now to give you a flavor of what some of the schools went through during this pandemic by having two teachers share their experience, particularly the impact on students and the wider school system.
I'd just like to introduce myself. My name's Matt Ridgill. I'm assistant principal at Derby College. So I'd just like to provide a message from older school children. So we're a large multi-site institution. So we have 5,000 students at our range of sites. And on my site, we have 1,600 students at the Joseph Wright Centre. And I want to start off just by giving a bit of context. We had 55 positive cases since the first lockdown, and 156 students had been isolated, having been identified as close contacts. However, in contrast, 362 were isolated because they have household close contacts, so far more. And equally, similar to what Paul echoed there, is we didn't have any evidence that where we had isolated a student that they had gone on to test positive, which we found really interesting. Similar to Paul, we felt that the experience and the extensive government guidance was really clear, and we did have a lot of support from, as Paul said, the Association of College Leaders, of Schools and College Leaders. There was a lot of narrative, there was a lot of support, there was a lot of examples, a lot of best practice was shared. Although it was still particularly difficult to interpret, given the other context that we wanted to achieve. So particularly early on, we were very keen to consider how we can maximise face-to-face learning whilst restricting travel to our city centre site. We also were keen to consider how we can get quick and easy access to our site. So my site is a large site, but it only has one entrance. So we were very keen to get quick access to site whilst maintaining social distancing and promoting sanitation on entrance. We also wanted to reduce interaction between student bubbles without disadvantaging particular student groups. We also looked at how to isolate close contacts without by minimising those that come into contact with. We're also looking about reinforcing compliance, particularly with mask wearing, whilst being inclusive to all learners and recognising not all students would wear a face covering. So there was a lot of interpretation, a lot of things that we had to refine over time, and we do feel we have refined that over time. Definitely the most challenging aspect has been the clear communication, despite the changing guidance and that has increased and decreased at several times, and on our eagerness to maintain positive behaviours. So particularly mask wearing. At current time, we wear masks at all times on site, so in classrooms, but that's been a change over time, and as the weather improves, obviously it's important that we maintain our compliance, and that's something that we've really stressed. So I do want to touch on the staff and student experience. So the staff experience has been about comprehensive change. So as we hit first lockdown, it was very immediate that staff had to adapt quickly their teaching and learning assessment strategies to go fully remote, and often create whole new schemes of work and lessons for students. It was significant demands to retrain and upskill. There was a wide range of competencies. And then as we return to site and we start to have more face-to-face teaching, we have adapted classrooms. So staff members have a 2 metre zone at the front of the class. They have responsibilities for cleaning. They have somewhat of an isolated working environment where they're either at home for long periods of time, completing remote working or remote teaching, or they have restricted classrooms, staff rooms, sorry. We have no movement to other campuses due to our site bubbles, which restricts our opportunities for sharing a best practice face-to-face and that interaction. But staff have really risen to that challenge. And I would say that that's been echoed in the student experience too. So we heard earlier about comments that Michelle Obama had said about resilience, and I like to think our students would demonstrate those characteristics. So they've had significant changes to their learning. Most of our students are post 16 and therefore are only signing up for a 2-year course in many scenarios, and they are completing a course that they didn't sign up for. So in many aspects, it started with a heavy remote provision, often 2 or 3 days off-site at home learning remotely, with two days on-site. There's a reduced social element to their learning, so we have no use of communal areas on site. So where there are some eating and drinking, they are done in class bubbles, in classrooms. But yet we've seen retention of our students been the highest it's been for years, and students have maintained their focus on their studies, and their attendance is been better in previous years. But we have seen increases in mental health need and the support that we've had to provide. So there's been a very different experience, and students have persevered, and obviously we are going into a period where we are now providing teacher assessed grades. So not only do they start on a course that was very different, it will often end in a way in which they will not be rewarded, will not be awarded their grade the way they're expected. So students are still persevering, and that's to their credit. But I'll just finalise by saying what did work. So we think we've had very large successes. We think restricting access to our site was very positive. So we had, and we still have, significant online remote learning. We learned quite quickly that our physical adaptations, and in particular our adaptations in our classroom, was likely to be particularly important. So much of the people we isolated, much of the students we isolated as close contacts, we actually did nearly a fifth of students in the first week of September, as we found it quite difficult to identify those close contacts. But as we started to get seating plans in for all hours of the day, be that class time or lunchtime, we found it a lot easier to minimise the people that we identified as close contacts, and that was definitely allowed us to restrict and maximise learning whilst protecting staff and students. There's significant adaptations to the college, so we have one-way system, we have sanitation stations on entrance and around the college, we've got staggered movement times, we've got staggered start and end times, we've got no or reduced use of communal times, we've got changes into classrooms too. But we've also got very good face covering compliance, and our students being 16 to 18 have risen to the responsibilities. In terms of what's not worked so well, social distancing has been difficult. So like I said, we have 1,600 students, and often that can be quite difficult to maintain at all aspects, but also off-site. And then just to finish, as we're getting some moments to wind down, I'd say inconclusive and still yet to be confirmed on what works well is our voluntary testing. So we have many tests that are still to be picked up and completed by staff and students, and so that's something that we need to see the impact of, and whether more will complete that. But I'd like to end on a positive note by saying we've not had any positive tests from students at the Joseph Wright Centre since Easter, and our staff and students are looking forward to reaping the benefits of that improved picture across Derbyshire.
Thank you very much, and we're going to move very swiftly in the interest of time to Oliver Lawton. You heard about him from the President-elect earlier. Oliver is a student of St. Joseph's College in Stoke, and he will be talking about his social study.
Hi, my name is Oliver Lawton. I am now 15 years old and in Year 10 at St. Joseph's College in Stoke-on-Trent, studying for my GCSEs. Last year, when the coronavirus disease was characterised as a pandemic by the World Health Organization, national school closures were imposed. By 23rd of March across the country, pupils like myself were then trying to work out how to continue their education at home. The focus was on IT and communication then. The availability of equipment, the use of online platforms, adapting to new teaching methods, and working out how to best communicate with our teachers. With the news always being on the TV at home, I was aware of the developing pandemic. A couple months into lockdown though, my younger brother one day asked, why can't we go back to school? We chatted as a family about COVID-19 and why we were isolating. It was then that I realised that there may be other young people that don't really understand why they are at home, or what the pandemic even is. We chatted about the scenario that there may be more young people not really understanding what COVID-19 is, and we noted that there wasn't any information available for young people on the pandemic, that we knew of anyway. My mum then suggested I did a survey to find out how others, like myself and Lawrence, my brother, accessed information on the pandemic. My mum is the head of operations for the Keele Clinical Trials Unit in North Staffordshire, and together we discussed the idea of the survey with Professor Christian Mallon, head of Keele School of Medicine and a professor in general practice. He loved the idea to carry out a survey, and so, with the help of Professor Mallon and the Keele CTU, I looked at some literature on the subject, designed an online survey, and applied for ethics approval to carry out the research study. I am now delighted that the results of my research have been published in the BMJ Open Paediatrics, and I have learnt so much about research. My school too were very supportive of me completing this work, which I did alongside my homeschooling. It has also made me really keen to pursue a career in medicine later. I'm now going to provide you with an abstract of my publication to give you more insight about the research which I conducted. Whilst the risk associated with COVID-19 appeared to be less severe for young people, the pandemic had still had a significant impact on their lives. Accurate information on COVID-19 is critical, yet at the time of designing my study, little was known about what sources of information young people had. The aim of my study, therefore, was to investigate whether young people had access to reliable information on COVID-19, how they accessed information, and to what extent they perceived that COVID-19 would impact their education. I designed and conducted a cross-sectional survey of pupils aged 11 to 16 in North Staffordshire, UK. I piloted the survey on a representative group of young people, and the feedback was incorporated into the final approved survey. The content included questions on the following topics: the frequency with which pupils updated themselves on COVID-19 specific information and the sources of information they accessed, how pupils assess the trustworthiness and understanding of information, an understanding of whether pupils believe COVID-19 had affected their education, and the kind of information pupils felt that schools should provide on COVID-19. The survey was called SOCIAL, which stands for Study of COVID-19 Information Accessibility for Young People in North Staffordshire, and the logo behind me I designed for the purpose of this study. Approvals were obtained from Keele University School of Medicine Ethics Committee and 2 secondary schools that had agreed to participate. Pupils were sent an email which explained the study and contained a URL link to an anonymous online questionnaire. 408 pupils, or 23% of those invited, completed the survey. 65.7% of these were female. Descriptive statistics were then used to summarise the data collected. 91.2% of pupils reporting having daily access to the internet on a personal electronic device. When asked to reflect on how often they kept themselves updated on the COVID-19 pandemic when schools closed in March 2020, 46% of participants reported keeping themselves updated on a daily basis. This trend, however, did not continue. When asked the same question at the point of survey completion, July 2020, daily updates were only reported by 10%. The data also evidenced that the older the pupil, the more frequently they kept themselves updated on COVID-19 developments. Participants reported accessing multiple sources of information. Television news was the most frequently accessed by 72% and was the most trusted source of information by 60%. However, it was best understood by only 26%. Social media was a significant source for the provision of information, with at least one social media medium being accessed by 68.1% of participants. Participants did, however, display some awareness that what they may be accessing may not be entirely trustworthy. Whilst parents had a strong role in aiding understanding of the pandemic developments, teachers and healthcare professionals held a very small role in the provision of information. Only 6% of pupils reported receiving any information from teachers on COVID-19, and 88.7% of pupils felt that to some degree COVID-19 had negatively affected their education. Social has demonstrated a gap in the provision of information on COVID-19 for young people, particularly on regulations and keeping safe, global updates, and what personal impact pupils can expect in terms of their education. I worked together with some of the academics from Keele University to interpret the results, and we agreed that the results of the study could be used to guide information campaigns by the Department of Education, the NHS and the media. Thank you.
Thank you very much, Oliver. Really very insightful and very innovative. For those of you who don't know, Oliver is live with us, and I'm just going to ask you, Oliver, thank you so much. It's very, very brave young man to come to here. Can you just tell the audience how this study has changed you?
Well, it's given me appreciation for what goes into a research project or a research study, and it's given me appreciation of the actual job of being a researcher, because prior to the study I don't really know much about what that was. It's also clarified that, like, what I want to do in my life, I want to be involved in well, medicine mainly, and being a medic, career in medicine.
Really impressive.
Thank you very much. So moving on quickly, I am absolutely delighted to have Professor Russell Viner, the president of the Royal College of Pediatrics and Child Health, still the president, I believe, who's going to tell us about something that is far more important than COVID in children. We know children have been relatively spared by COVID, but I think the indirect effects of the pandemic is going to haunt us for many, many years to come. And Russell has been a great proponent of trying to protect the children from the long-term effects of the lockdown and school closures. So Russell, it's all yours.
Thank you. Thank you, Shamez. Thank you, colleagues, and good evening. I hope to bring us a little bit back to time. I'm not going to show you any slides tonight, so because I want to talk through data, but I don't want to show you too much. I wanted to share with you some reflections, I think, on our time during the pandemic. And yes, Shamez, I am still president for 10 days. But in 10 days' time, there's a wonderful event when the brilliant Camilla Kingdon takes over, which will be brilliant. So, absolutely, COVID-19 has been a dilemma for paediatricians, for child health professionals right from the beginning, because it was a challenge to us in terms of our clinical perspectives compared with our more population public health perspectives. From a clinical perspective, we have had children and young people go to intensive care. We have had the new PIMS condition, which has made some children seriously ill. And we have lost a small but important number of children due to COVID-19. And from a clinical point of view, that's hugely serious. And when we hear about countries that are currently being overwhelmed by COVID, such as Brazil, and more recently, this very sad stories we see from India, we hear about more children being infected, partly because of sheer numbers, deprivation, poverty, etc. But actually, from a population point of view, COVID barely has affected children at all in a direct sense, but children have been hugely affected by the response to the pandemic. And I want to talk to you through, in a sense, how our understanding of that evolved. But I think it's perhaps useful to say at the beginning that within the college, much of our advocacy, certainly for me personally, but through the college, has been trying to get that dual focus right. The focus on the clinical responses to COVID, helping paediatricians challenged by seeing sick children presenting during COVID times and understanding how to treat this new condition and the even newer one, PIMS. But from a more public health point of view, trying to get children on the agenda. So if you recall right back at the beginning, in February of last year, we started to hear these rumours coming out of China, and we started to hear about awful events evolving in Italy in particular, Iran and Italy at that stage. There was a very strong message very early on that children were barely affected. There was an early report of a 14-year-old from China that had potentially died of COVID, and we were trying to track down the truth of that. We were ringing colleagues in Italy, and at the time on the news, the Italian health system was supposedly close to collapse, and our colleagues were telling us their children's intensive cares were empty and their children's wards were empty. And we started to get a strong sense of the clinical realities of this disease for children. We relatively went into lockdown in this country. Let's not get into those discussions. There were lots of debates about school closures early on and the utility of those, and you've spoken a bit about that already. But we had a broad national lockdown. And what's interesting, if we look back at the data, the group that had the greatest reduction in social contacts or social mixing were children and young people. So social lockdown, the effectiveness of lockdown is all about reduction in one-to-one contacts between humans, because that's essentially what spreads etiological agents such as viruses. And of course, the groups that have the highest social contact rates in the population are those who are under 25. So young children, teenagers, young adults. And in fact, if we look at before and after surveys, and there are data, it's children and young people that had the greatest reduction. Of course, many of the modelers, the infectious diseases modelers, assumed that COVID would be transmitted in similar ways to influenza, that children would be the vectors, etc., and that closing schools would be the most important part of our response. That proved not to be the case. But partly because of that high social mixing rate, children and young people were particularly impacted by the pandemic. So there's two issues. Firstly, that big reduction, and secondly, we shut down the safety net that we as a society have spent 50, 100 years building around our children. So our children's wards were often closed or reconfigured. Health visitors in most areas, many areas, were shut down and redeployed into adult intensive care or wherever. Social workers weren't able to work, schools were closed. So all of the much of the protective safety net we built around children was shut down. We recognised this very early. We recognised the potential for issues. But it was when we started to see delayed presentations. We started to get phone calls. I got phone calls as college president. We started to get reports of children being delayed and potentially dying. And it's one of the great tributes to the BPSU under the leadership of Shamez and his board, supported by the college teams, that actually were very rapidly able to do a rapid snapshot review of what was happening on the ground. We had a strong response from paediatricians, and there was a series of very disturbing reports, including 8 children or 8 deaths, where paediatricians believed that delayed presentations had significantly impacted. This was incredibly powerful to me as college president, to us, and working strongly with NHS England. We were able to work with NHS England, work with the chief medical officer and others, make sure this information got to the CMO, got to the health secretary, got to the prime minister, so that people were starting to recognise the very real downsides of this lockdown. There were some very clear actions we took in terms of changing the NHS 111 systems that NHS England enabled us to work with them to do very rapidly, to make sure that paediatricians and clinicians were involved in the triaging of children. But there was a big media campaign to send out messages. The NHS is open. If your child is sick, bring them to hospital. So BPSU data was absolutely hugely important in that. But more than that, we started to get concerned, particularly about a range of issues, about whether vaccination coverage was staying up, about whether we actually had the ability to see child abuse cases. How was our child protection system operating? And there was clearly the issues about loss of education from children being out of school, but the real issues about mental health and well-being. We started to hear a lot of reports about how concerning this might be. That's the English situation. Of course, internationally, schools are places where health goods are delivered. So nutrition is delivered. School feeding programs are essential to the health and well-being of millions of children in lower middle income countries. Deworming programs, provision of menstrual hygiene, that's what schools provide, a bunch of health goods. They are platforms for the delivery of health. And of course, all of that was terminated because every country in the world, I think bar 3, Taiwan, Singapore, I don't think New Zealand ever closed schools either, and Iceland didn't close any of, well, actually Iceland closed some of its schools. So very few countries didn't close any of their schools. We were able to check because Britain has superb data. England in particular has superb data. For example, we're the only country in the world that has statutory requirement to report child deaths within 24 hours or 48 hours, I think it is. So we were able to track death changes, mortality changes due to COVID, and started to see a signal around potential rise in suicide mortality amongst teenagers. Hugely concerning to us. We tracked that with NHS England, with the National Child Mortality Database, and we were able to get that data into the system, up to the CMO, Health Secretary, Prime Minister as well. And it's interesting that much of this data, these data I should say, were really quite instrumental in making sure that schools opened early. If you recall, there was a commitment at the beginning of May to open primary schools on the 1st of June last year, and that was hugely important. We weren't able to get secondary schools open, but we were able to get primary schools open. But essentially, when you close down schools and broader society, you close down the social mixing that is so important to children's health and well-being, and you close down our ability to both support them and watch children. Sorry if you can hear whistling in the background. It's my 15-year-old practicing whistling. I've told him to desist, but anyway. So there were a range of other indirect effects, some clearly causally related to schools. So causally related to schools are particularly around education loss, the loss of development, and the loss of travel to school, and the loss of exercise, routine and peer relationships that children and young people get at school. And we've heard that very passionately, much better than I could ever talk about. Then there's the causal impacts from broader lockdown, which are about potential lack of access to services, which we saw early on. But it was important to say we think largely our health system dealt with that quite effectively, but a range of other potential impacts. Briefly on health systems, we know that right across all high-income countries that attendances to ED services and inpatients, and admissions to hospital were down by 30 to 70%. We had a skewing of admissions, particularly with a reduction in less severe presentations to emergency departments, a reduction in overall admissions. We believe largely a preservation of those who needed to come to hospital, but the proportion of those admitted who went to intensive care went up, unsurprisingly. The biggest concerns for me, I think, from this pandemic will be the longer term ones. That's partly about loss of education. There is an incredibly direct relationship between years of education and mortality and life expectancy. Those who are better educated live longer lives with greater health. They have fewer non-communicable diseases. Even a 6 month, and don't forget, many of our children have been out of education for 6 months, even in this country. And in other countries, Italy, America, there are many children who have actually been out of school for nearly a year. Those children will probably have a shorter life expectancy unless their education is made up. And the evidence is clear that online education doesn't make that up. So I think there's real concerns about the loss of education causing higher death rates in the long term, which is ironic because schools were closed to reduce death rates now amongst the middle-aged and elderly. And I think some of our arguments have been that actually this balancing of mortality has actually ignored the fact that reducing education reduces life expectancy, increases mortality in the longer run. But I think the real concerns are around mental health. And we heard some wonderful stories today from previous speakers about resilience. and that's hugely important. But we also know there's other young people who haven't been resilient. The data, the national data on mental health are concerning. The same survey taken in 2017 and then in July 2020 with the same children, a nationally representative group of children and young people, suggested that mental health problems had increased from 1 in 6, increased from 1 in 9, I should say, to 1 in 6 across those 3 years. We can't prove that's due to the pandemic, but actually for 2 to 3 years, it's incredibly unlikely that that's due to anything else. And those data were collected in the summer, which was post-lockdown. So there are very real reasons to be concerned. We did a systematic review recently, which is currently under peer review, which showed really quite extraordinary estimates of the mental health impacts. We also recognise there are impacts, very strongly likely impacts on obesity, on diet, and on broader elements of child protection in ways that we do not understand. There are significant impacts on our waiting lists. There's some estimates that it may take us up to 2 to 4 years to make up our surgical elective waiting lists for children unless we increase capacity. Unsurprisingly, as in all things, those from poorer families have been more affected by both COVID itself, but by the indirect effects of COVID. That is true of almost every condition that we know of, and it is absolutely true of both any of the direct effects of COVID and definitely true for the indirect effects. So the government's response has been to borrow £300 billion. There is only one place that government borrowing comes from, essentially, which is largely from the futures of our young people and our children. If we have an economic renaissance over the next 10 to 20 years, maybe we will pay that off quickly. But otherwise, that is a debt which is essentially borrowing from our children's future to pay for the health of the middle-aged and elderly. So we owe it to our children and young people to recognise these indirect effects and actually recognise that this last year has been the year of the pandemic and the response. But now we've vaccinated adults. The next few years need to be the years we give back to children and young people who have given so much during this pandemic. Thank you.
Thank you very much. That was brilliant. I mean, you kept to time and without slides. That hats off. That was really, really good. And I definitely agree with you. I had never thought about the financial impact of this. We are borrowing it from the children, and I think it's going to take a long time to pay that back. Russell, thank you very much for that talk. We will try and fit in some questions at the end, but at this stage, I want to make sure that all the speakers get their opportunities to speak about their topics so that at least we cover what we have promised. So without further ado, I want to introduce you Dr. Liz Whittaker. She's a pediatric infectious disease consultant and a very good colleague of mine who works at St. Mary's Hospital and at Imperial College London. And I actually asked her to give her this talk because sometimes we forget there's a world outside COVID, and you know, a lot of the infections that we were seeing before COVID have sort of gone into hiding, and it's really important to try and understand what that means for now and the future. So Liz has had to work with very little data in very little time to produce this presentation. I'm very thankful to her. Liz, the floor is yours.
Oh, thanks, Shamez, and it's a really hard act to follow. And thank you so much for inviting me to come and speak today about what's happened to infections during the pandemic beyond COVID. So I am an infectious diseases consultant. I love infections. It's a bit weird, but actually infectious diseases are our bread and butter in paediatrics. You know, a huge number of our admissions and presentations to hospital are associated with a variety of infections, and some of which are colourfully described here because I'm a paediatrician and I like things to be pretty. And then you throw in all the really fascinating things that really drew me to global health and infectious diseases. So, and we know, and you look at global mortality, particularly in the under 5s, that infectious diseases make up about 60%. So they're a really important area to know about. And what we were worried about during the pandemic was what was happening to all the children who normally came in with infections and where had they gone. And so the BPSU, showing its brilliant prowess, did a survey last in April and showed that there was a significant delay in presentation with sepsis, amongst other things, that was resulting in poor outcomes for children. And this is just pictorially described here in this graph, which is just showing how the emergency department attendances kind of shut down during the pandemic last year, and that's mirrored as well in inpatient admissions, which you can see here in black, against the norm of the last 5 years in blue dotted lines. So we've had a real decrease in inpatient admissions to hospital over the last year, and it's really interesting to think about why that is. And we've put a number of measures in place from Public Health England, you know, hands, face, space, who can't say that without a smile on their face, and we've closed down a variety of areas for some or all of the year, including nursery schools and pubs and restaurants. And which of these has had the greatest impact, I think, is quite an interesting question. And when you look at this data from August last year, looking at some of the things that we are interested in, so scarlet fever and group A strep both decreased in the second half of the year, and actually this really interesting decrease in measles and mumps, which, you know, we've always had a little bit of an ongoing spread of measles, and particularly in the last few years when our vaccination hasn't been perfect, and that's just been wiped out by simple measures that are public health measures. And look at this, this is really interesting to me. So gastroenteritis, rotavirus and norovirus, we've managed to get rid of it despite, you know, we've tried to do this with vaccination, but actually it comes this way. And my question is, why weren't they washing their hands before? But clearly a very effective measure, and I'm so horrified that we have to tell people to wash their hands. There you go. So this is what COVID has looked like in terms of numbers over the last year. It's a pretty scary prospect. But in other places, they've had a different picture. So this is just the New Zealand story, where basically they had more cases in less cases in a year than we've had on some days in this country, and certainly significantly lower numbers of deaths. But what's happened to their children and infections? And this really interesting research letter from Auckland, just looking at young children under the age of 2. And what you can see down here is that they've just had absolutely no RSV or flu in 2020. What's interesting is that they've continued to have rhinovirus and a slightly reduced amount of adenovirus, which are the two other viruses that they looked at. And this slightly broader paper looking at the Australian infectious diseases has shown a 98% reduction compared to expected cases of RSV and influenza, and particularly in these different periods, which is kind of closure, but after the reopening of things when we had a little bit of flu. But keeping the borders closed appears to have had a great influence on our winter respiratory viruses in the Southern Hemisphere. But what is interesting is that as things opened up a bit, they've had a very unseasonal but late RSV pandemic or epidemic towards the end of 2020 as they went into their summer. And as you know, they would normally see RSV here in their winter, but it came in the summer instead. And in fact, it exceeded the expectations that they might have had. And this has also been seen in South Africa, where they've had this late RSV outbreak that's happened at this stage here. And interestingly, just looking at some French data, where again, over the winter, they've had no RSV. In March and late spring, which is aligned with what happened in the Southern Hemisphere, they've had a little outbreak of RSV, although not compared to the normal peaks that they'd seen in previous years. And what have we seen in the UK? So there was a paper looking at this in England, and has shown that they've had a complete decrease in the cases of flu A and flu B over here. And what we can see over here is a complete lack of cases of RSV over the winter. But what was interesting is that there was a rhinovirus outbreak as schools went back. So rhinovirus is very different. And so what we can talk about is there's been a really significant reduction in respiratory viruses in both the southern and the northern hemisphere winter. Why is that? Is that because of the public health measures I outlined before? Is it the international border closures? I mean, I guess the virus has to come from somewhere. Is it the, inverted commas, the mandatory 14-day isolation that everyone keeps to really well? Is it because of viral interference? Is having a co-infection with COVID impacting on the ability for these patients or the other viruses? Is there something happening at an innate immune response level? It's a really fascinating question. Is it that people took the flu vaccine because they were so freaked out by COVID-19 that the flu didn't come about? Or is it multifactorial, as many of these things are? But it has implications, particularly on how we choose the influenza vaccine going into this winter, because we normally base it on what's happened in the previous year, both in the southern and northern hemisphere, whereas we're going in a little bit blind this year. And actually, as a clinical trials person, and the RSV vaccine and monoclonal antibody trials that are ongoing really don't know how we're going to have any outcomes or endpoints. And perhaps it's all too good to be true, because what we can see is that in Australia and South Africa, they've had a really horrible outbreak of RSV because of a lack of immunity at the end of a winter. And do we as paediatricians need to be quite worried about what's going to happen next? Some people are suggesting that we might start to see RSV early, so perhaps even over the summer, which would be disappointing because I think we all need a break in the summer holiday. Or are we just expecting September, October? So we normally start to see it in the beginning of August to be pretty scary from a paediatric respiratory perspective. We normally have about 35,000 presentations to hospital with RSV in the UK every year, and this has a huge impact on our ability to deliver care. And it comes back to this question that comes up a lot, which is the children are the super spreaders of winter viruses. I know you've heard over these meetings about how that's just not true from a COVID perspective, but it is kind of acknowledged that they probably do contribute to flu spread because they have relatively asymptomatic and mild disease. Although, interestingly, schools were open going in the autumn and the winter, and yet we didn't see an outbreak this year, but the pubs were closed. So I have to question that actually it's the adults who spread all of these infections. And maybe it's just for rhinovirus. So what we can see here is that when the schools reopened, we saw that stark increase of rhinovirus amongst adults. And so interestingly, rhinovirus appears to be different. Why is that? Is it just that we're testing more than we normally would? And so we've picked up cases that weren't there before because we're making sure it's not COVID? Is it filling an RSV influenza void? Is there viral interference? Is it that surgical masks are less effective at preventing rhinovirus, and the fact that it's got a lipid envelope makes it more less vulnerable to the hand washing and alcohol wash measures that we've been using? And interestingly, there's this study, the Open Safety study, which shows that adults living with children were actually marginally protected from COVID-19. And this might be because the children share their snot. And so is this the bonus result of the snot, is that you have a lower risk of serious outcomes with SARS-CoV-2? And it turns out that children may be good for your health. And there's further paper that shows that adults who've had a recent cold were less likely to have a severe outcome with COVID-19. So thankfully we work in paediatrics and we get plenty of exposure that way. So I do think we just need to consider, and my final slide, that perhaps we need to think differently about winter viruses. In Asia, wearing a mask when you have a cold is pretty standard, and it has been for some time. And perhaps we all need to adjust our thoughts. We need to have a social difference in how we behave when we even have a mild infection, because it may have implications for other people. Should we be quarantining patients who've got RSV? Is this not protective? And maybe that's not the right thing to do. So we've got lots of research studies that are going to be ongoing in the next few months to try and answer some of these questions, including BronchoStart from Peruki, which will be in your A&E department. So do recruit to that, please. Thank you for listening.
Elizabeth, thank you very much for that talk. And actually, thank you for gaining us a few important minutes so we can try and finish on time. That was a very, very clear message, and we'll try and keep the questions to the end of the talk. But there is a live Q&A session where you can answer questions if they're for you. I would like to move on to Professor Paul Heath, who has been my teacher and my colleague for the last almost 20 years now. We've worked very closely on all aspects of pediatric infectious diseases, but we have a common interest in perinatal infections. And I'm very grateful to him to come and talk to us about vaccinating against COVID in pregnancy. Thanks, Paul. All yours.
Thank you, Shamez. I trust you can see my slides okay.
Yes.
So great. So just let me start with this. This is the virus that we're all that we're speaking about at the moment, and the cartoon there demonstrates the important proteins, and of course the one that we're most concerned about is the spike protein, and it's important clearly in pathogenesis and in terms of immunity as well. So that's reflected by the fact that most of the vaccine candidates, of course, target the spike protein. And in terms of the COVID-19 vaccines, of course, this has been a hugely accomplished pathway, and we're all astonished by the rate at which these successful vaccines have been developed. There are a number of reasons for that, as shown there, but the first vaccine, of course, was the Moderna vaccine, the RNA vaccine. That was the first vaccine to go into humans, which was an astonishing 63 days after sequence selection. One of the other interesting aspects of the COVID-19 vaccine development is the different platforms, the different technologies that have been used, and they're listed there. Of course, we're very familiar with inactivated vaccines, live attenuated vaccines, subunit vaccines, but we were not very familiar with the nucleic acid vaccines, RNA and DNA vaccines, and viral vectored vaccines. This slide shows the current status of COVID-19 vaccines, and this is taken from the London School website, which I recommend to you to find more information about COVID-19 vaccines and their development. What you can see is that there are more than 300 vaccine candidates, 81 of which are in clinical testing at the moment. And then down the left-hand side of that table, you can see the different vaccine types, the different vaccine platforms. And although the majority of them, or the highest group, are the protein subunit vaccines, with which we're quite familiar in terms of vaccines, there are, of course, these other vaccines, the RNA vaccines, DNA vaccines, and the viral vectored vaccines that stand out and are relatively novel, or indeed were relatively novel. You can also see the different clinical phases of their development, and of course a number now in phase 3, indeed some in the phase 4 post-implementation stage, and many, as we know, in use in different countries. This is a summary actually of the vaccine efficacy data. The top 4 studies, Pfizer, Moderna, the Oxford AstraZeneca, and the Gamaleya, which is the Russian Sputnik V vaccine, are all published. You can see those percentages. This is efficacy against symptomatic PCR proven COVID-19, all very high efficacies. The bottom 4, Novavax, Janssen, Sinovac, and Barrett Biotech, are all press releases at this moment, and we await the peer-reviewed publications, but nonetheless very high efficacies are being seen here. So this is now across a range of different vaccine types: RNA, adenovirus vectored, protein subunit, and inactivated vaccines. There are some differences here, of course. Most of these are 2-dose schedules. The Janssen is a 1-dose schedule. The other important finding is that these efficacy figures are high, but they're even higher for severe COVID. So the efficacy against hospitalization, intensive care admission, and death is even higher. They're also impressively effective in the elderly, who are, of course, so important because the burden of disease was greatest in that group, and in adults with other comorbidities. This slide I like. This demonstrates the speed with which the COVID-19 vaccines have been implemented, and that means, of course, we now have vaccine effectiveness data, how these vaccines work when implemented in the wider population. And we have that from several countries now, Israel, and particularly from the UK. And you can see all of these figures are impressively high, demonstrating the effectiveness of these vaccines. So what does that mean for maternal vaccination? Well, the first thing is, what is the risk of COVID-19 in pregnant women? Now, these data are from a living systematic review. The reference is there. Here we can see the outcomes in pregnant women with COVID-19 compared with non-pregnant women with COVID-19 in the top part. And you can see there's an increased risk of ICU admission, invasive ventilation, use of ECMO in pregnant women with COVID-19, and then below that in pregnant women without COVID-19. And women with COVID-19 have a higher mortality, ICU admission, preterm birth, preterm delivery, and a higher rate of stillbirths. It also tries to tease out the specific risk factors amongst pregnant women, risk factors for severe COVID-19, and there are some. So higher age, more than 35 years of age, for example, more obese women are at higher risk, those of non-white ethnicity, and those with some other comorbidities, including chronic hypertension. Women with diabetes, and women in particular with gestational diabetes, as well as those with preeclampsia. So we recognise, therefore, that pregnant women are at higher risk of more severe COVID-19, and there are some risk factors amongst pregnant women that yield an even higher risk. There are, of course, a number of unknown questions about COVID-19 in pregnant women. We need to know more about the extent of asymptomatic and mild infection and the implications of that for the fetus and the infant. We need to know more about the short-term and the long-term burden. And of course, we as paediatricians are particularly concerned about the long-term burden, neurodevelopmental outcome, for example, in infants born to women affected by COVID-19. We're of course very conscious of some other important viral infections in pregnancy, Zika virus, rubella, CMV and the like, which of course do have significant consequences for the fetus and for the infant. And of course there are a number of studies in progress, and some of these have been mentioned already today, that are addressing these particular questions. So turning to vaccination in pregnancy and the opportunity that that provides for protecting pregnant women and potentially their infants against COVID-19, we first of all can learn from the experience in the UK with the pertussis vaccine. You're all very familiar with this. Very successful, very effective, 90% effective at preventing pertussis in infants less than 3 months of age. Similarly, influenza, this is a nice study, this is from Bangladesh, but it reminds us that the influenza vaccine in pregnant women is not only important for protecting them against influenza, but also for protecting their infants against influenza. And this is a more recent demonstration of the power of maternal vaccination, and this is with an RSV vaccine. We've just been, Liz has been telling us about RSV and the concerns potentially for this season or maybe out of season. The RSV fusion protein vaccine, so this is the F protein, the fusion protein from the virus with an adjuvant, aluminium phosphate. This was a study from Novavax, a phase 3 randomized placebo-controlled trial involving 4,600 pregnant women, including sites such as our own from the UK. They were vaccinated at 28 to 36 weeks gestation, and the primary endpoint was RSV, lower respiratory tract infection in infants less than 90 days of age. The first important result is that there were no safety concerns. Secondly, there was a reduction in a number of endpoints related to RSV. So there was a reduction in RSV lower respiratory tract infection, alas, so a 40% reduction, alas, with the stringent 97.5% confidence interval applied, it didn't quite reach statistical significance. There was a reduction, however, a statistically significant one, in RSV lower respiratory tract infection hospitalization. There were also some other important conclusions from this trial. So, for example, the earlier in pregnancy that women were vaccinated, the better the outcome, the higher the efficacy at preventing some of these important outcomes. So the lessons learnt from this will now apply to other pregnancy vaccine studies. So if I now come back to COVID-19 vaccination of pregnant women, I showed you this slide before, but it's important to remember that the majority of the COVID-19 vaccine platforms, particularly the RNA, DNA, viral vector platforms, have never been assessed in pregnant women. And of course, all of the phase 3 trials excluded pregnant women and breastfeeding women. So what evidence do we have? Well, first of all, we go back to general principles about vaccinating pregnant or breastfeeding women. The first is that there is no evidence of risk with inactivated virus, bacterial vaccines or toxoids. Inactivated vaccines, of course, do not replicate and so cannot damage the fetus. And of course, some are actively recommended in pregnancy. Live vaccines, of course, are generally contraindicated in pregnancy, and this is because of a theoretical risk of fetal infection. But it's important to remember that there is no evidence to date of direct fetal injury from a live vaccine given in pregnancy. And of course, in some circumstances, live vaccines are recommended in pregnancy. And this is just to, this is with the Ebola vaccine. This was a live Ebola vaccine. This was WHO recommendations for its use in pregnant women in the context of the Ebola outbreak. The adenovirus vectored vaccines, just to remind you, is a live adenovirus vector, but it does not replicate, and so it cannot cause infection in the mother or the fetus. We do have other data. There is reproductive toxicity data for all of these vaccines in their development, and this does not or did not demonstrate any evidence of harm. And of course, in the phase 3 trials that I alluded to, though pregnant women were excluded, a number of pregnant women were inadvertently vaccinated, and no known safety concerns have emerged from that. But more than that, in those countries that have aggressively vaccinated the population, that has included pregnant women. And so in the USA, it's estimated that around 100,000 pregnant women have now been vaccinated, and that's principally with the Pfizer and the Moderna vaccines, and there have been no red flags. There are now some current pregnancy studies in pregnant and breastfeeding women addressing issues such as immunogenicity and reactogenicity and safety. So specifically with the Pfizer vaccine that is underway, and also in the UK, led by my colleague Chrissy Jones in Southampton. The Janssen vaccine is also underway in the UK. There is a planned AstraZeneca pregnancy trial, but that hasn't started. I'll also advertise the COVID study, which is a service evaluation following women who are vaccinated, and that's led, in fact, by Shamez Ladhani and the team at Public Health England. And then PregCough, which is a trial led by us at St George's. So pregnant women should be provided, of course, with a balanced and clear assessment of their risk of COVID-19, taking into account individual circumstances, local practices and available evidence. And they should be counselled with a balanced summary of the potential direct and indirect benefits of COVID-19 vaccines, whilst acknowledging the current lack of safety data. But it should not be withheld from pregnant women who've received adequate counselling and understand the uncertainties, the minimal potential harms and the likely potential benefits. This is the current JCVI statement on vaccinating pregnant women. Women who are pregnant should be offered vaccination at the same time as non-pregnant women based on their age and clinical risk group. And the current vaccines recommended for pregnant women are the Pfizer and the Moderna vaccines. That's simply because there is currently more extensive experience of their use in pregnancy. I'll just mention the PregCough study. This is a study led by St George's, which will be starting shortly, and this is to address questions about immunogenicity, reactogenicity, persistence of antibody, including into the infant. The end point is this is antibody levels at the end of pregnancy, and we'll be following all of the children up to 12 months of age to ensure that there are no longer term issues associated with vaccination in pregnancy. And finally, let me recommend the RCOG and Royal College of Midwives website on COVID-19 vaccination in pregnancy, because I think this provides a very balanced view and is very, very useful for healthcare workers looking after pregnant women and for pregnant women themselves. And with that, Shamez, I will finish. Thank you.
Paul, thank you very much for that talk, and it was very, very extensive. And we would love to have questions, but we're running short of time. But I've just got a question posted to me, and I cannot think of a better person to throw a curveball to, which had nothing to do with your talk, but relies on your expertise and experience. So the question is, can you please advise of any research underway to identify the lowest dose of COVID vaccine for use in children, which will help to halt transmission, but have minimal adverse effects in childhood?
Well, thanks for that curveball. It's a great question, and I have to be honest, I'm not aware of any studies that are modifying the dose for children. So all of the studies in children at the moment are using the standard adult dose. And as you know, so there are vaccine studies in children that have commenced, with Pfizer, with AstraZeneca, and in fact with Novavax as well. Moderna are planning children's studies, but to my knowledge, it's the standard dose that is being used. It's a really interesting question, and I guess the first thing is we need to see what the reactogenicity and immunogenicity is in children. And potentially, if there are concerns there, particularly with reactogenicity, maybe that is a next step. But, great question.
Perfect answer. I couldn't have said it better myself. Thank you very much, Paul. Okay, so just to come to nearing the end of our talk, there's one last talk left, and that talk is is from me, and I have to play devil's advocate because I have to argue for and against myself. So the question over here was whether we should be vaccinating children in the current pandemic or not. So my first 5 minutes I'm going to spend, and I'm going to time myself, is to try and explain to you why it is important that we should be vaccinating children. The first thing is that children do get infected, and if you've been listening to the webinar, you should be convinced that children are as likely to get infected as adults. When you look at antibody studies, it's very clear that children's antibody levels are not that different from adults, and they're certainly not very different from the local community, which means that they are exposed to the virus the same as adults. It's just that they're more likely to have asymptomatic or transient infections, and they may not be picked up. So vaccinating them protects them from getting infected. We know that only a small percentage are hospitalized or need ICU or die, but it still happens, and they are potentially avoidable. If they don't get if they don't get the infection, then they will not suffer these severe outcomes. We also know that some children will develop persistent symptoms after COVID. This may be called as post-acute COVID syndrome. It may be called long COVID. And it is much less common in children, but there will be some children who will have a very prolonged illness after their initial COVID, and it may be related to their underlying medical conditions, for example, or other factors that we don't know. So if we can stop children getting infected, then the risk of long COVID goes down. Another important reason is that you've heard about the hyperinflammatory PIMS-TS syndrome in children, which was talked about in the first part of the webinar. Again, very rare, but potentially severe and fatal. And a lot of the work that we and others have done have shown very clearly that when you get a large surge in COVID cases in children, you will get PIMS-TS cases 2 to 4 weeks later. We believe that this is a direct consequence of an abnormal immune reaction to the initial virus, and therefore if you stop the children getting COVID, they will it'll reduce their risk of PIMS-TS. The second reason is that children can transmit to others. A lot of the data show that children are generally asymptomatic or have very mild and transient infection. It does suggest that they are very difficult to identify, and therefore people will not think about testing them because of the lack of symptoms, the minimum symptoms, and therefore it's difficult to isolate them as well because they're young and because you don't know they have the virus. It's also very difficult to maintain physical distancing from infants and young children, and unrealistic to expect us to be able to keep that distance when we are with young children, either in school or at home. The third reason is that there are so many vaccines that are already available and will continue to become available soon. There are already very encouraging clinical trial data which show very promising safety, immunogenicity, and even effectiveness studies in young children. And what you have to remember, at least for the UK, is that we have 9 million children at the moment, which is equivalent to 18 million doses. We've already bought 300 million doses of vaccine, so 18 million will only be a drop in the ocean if we really wanted to vaccinate all our children. And the good news is that we have an established immunization structure for which we can use to vaccinate them. We have the nasal flu vaccine through the schools program, for example. We have adolescent vaccination programs, and therefore it would be easy to repurpose them for COVID vaccination for children. And finally, there is the wider benefits that are more difficult to measure. So if you have fewer infections in children, you have fewer outbreaks in schools, you have fewer absences, you have less isolation from schools, and importantly, also parents can return back to work and don't have to take time off because their children are isolating or unwell at home. And also there is the added advantage that parents are reassured that their children are protected against COVID, and therefore it allows them to be more comfortable with allowing their children to have a normal life, to meet their friends and go to school. But at the same time, it's not that straightforward because there are equally valid reasons why we might want to think twice before we vaccinate the children against COVID. The first argument is exactly the opposite of what I've told you, is that children rarely develop severe disease or die. Even children with underlying comorbidities have a very low risk of severe disease or death. And most of them who get it have very mild and transient self-limiting illness. With regards to the rare outcomes of PIMS-TS, They are extremely rare, but we know the syndrome, we know how to diagnose it, and we have very effective treatments for it. And you would end up having to treat very few children for that instead of vaccinating millions of children instead. The data on vaccine use in children are very limited. You are giving them vaccines which are potentially reactogenic for a very mild transient illness. And the other thing is we always have to be careful about potentially rare adverse events. We saw that with narcolepsy and the swine flu vaccine. We saw that with severe anaphylactic reactions in the Pfizer vaccine. We're seeing them at the moment with the bleeding and the clots with the AstraZeneca vaccine. And these are unpredictable and need investigations. And while we are reassured that these vaccines have been tested in adults, we would want to be reassured that we aren't seeing such events in children who have such a low risk of a poor outcome with COVID that we don't want to end up in a position where the vaccine is causing more harm than the disease itself. Probably the most important argument against vaccinating children is that all the adults will be vaccinated. We know from many studies that child-to-child transmission of SARS-CoV is extremely low. There is very good evidence that actually most of the children are getting the infection from adults, usually adults in the house or in the local community. And the other thing is, even if children do get infected, then the only people they would be able to infect in terms of causing severe harm may be the teaching staff in school and household members, but they will already be vaccinated as part of the adult immunization program. So essentially what you would have is children who pass the virus to each other really badly. But that has an important implication in terms of long-term immunity, because we know that and that's number 5 actually, that there is a natural boosting of immunity. So you do need a little bit of virus. It will help develop the children's immune system, and vaccinated adults being exposed to the virus, it's how they boost their natural immunity or vaccine immunity, and that provides long-term protection. With regards to point number 4, we know, and there's a lot of data continuing to be acquired, that actually if you vaccinate adults, you get lower community infection rates, which is less likely to pass on to the children, who are less likely to take it to school. So, and there's some very good data from Israel coming through showing that actually once you vaccinate adults, the cases in children go down very quickly, which is again very reassuring. But probably the most important reason, I think, is before we start vaccinating our children, especially in the industrialized country, is that we are in a global pandemic. And if we start vaccinating our children, it means we're taking that vaccine away from other countries and other high-risk groups. And I just feel that right now there are many elderly people across the world who would benefit from vaccines. And something else that I think struck me and hasn't really made much of is the healthcare workers in developing countries. And if our healthcare workers are getting sick and dying of COVID in those countries, then that damages the health infrastructure to support the rest of the country. And it would be so much better if we could get vaccines to them, at least so that they can look after their own people. And with that, I thank you for your attention. I wanted to take this opportunity to thank all the speakers for the time, and all you listeners out there. Apologies that our timings were a little outside the range that we had. We have tried to answer all your questions online to the best of our abilities, and you have our contact details, so please feel free to email us if you have any specific questions about anything that we've discussed today. Thank you very much, and have a good rest of the evening. Good night.